Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Palpation is a diagnostic procedure in which the examiner feels or presses with gentle but firm pressure upon the tissues and structures of the body for the purpose of determining various characteristics present in the areas examined. Palpation has been an accepted diagnostic procedure in the health profession for many years. Its value is directly dependent upon the experience, skill, and clinical judgment of the examiner, thereby placing it in the category of an art rather than a science. It can be of significant importance in diagnosis to those clinicians who master the technique. Any thorough clinical examination of a dental patient should include palpation of the various tissues associated with the masticatory system. The head, neck, oral, and facial areas possess tissues associated with the masticatory system. It should be emphasized that palpation is but one segment of a complete examination for functional disturbances of the masticatory system, and in no way should be thought of as conclusive in determining the final diagnosis. The rationale for palpation is as follows: to detect areas which may be contributing to abnormal masticatory function, to confirm and evaluate sites which have been described by the patient as being uncomfortable, tender, painful, and so on, to aid in differential diagnosis, that is the source of the trouble in muscles or joints or both, to serve as an adjunctive procedure to other diagnostic findings in confirming a diagnosis, to serve as a method of evaluating the progress of a specific therapeutic approach. For example, it is employed previous to, during, and following bite splint therapy. The principles of palpation are: all applied pressure should be gentle but firm. Proper method of palpation should be used for the area examined. For example, bilateral when possible to compare similar sites, bimanual when indicated, such as in the floor of the mouth, bidigital when indicated, such as in the sternocleidomastoid muscle, and digital when indicated for the teeth. When feasible, palpate structures both at rest and during function. Watch for reflex reactions which indicate tenderness or pain. They're probably more reliable as signs than verbal responses from the patient. For instance, the palpebral reflex or eye blink, the nociceptive reflex or withdrawal or flinch. Verbal response to palpation should be carefully evaluated, particularly in patients with obvious emotional stress and signs of anxiety. A practical sequence in the palpation technique is desirable. Palpitometry, that is, the quantitative assessment of tenderness and pain, is notoriously difficult and is not attempted. Palpations of structures associated with the masticatory system is also desirable. For example, the neck muscles and the epicranial muscles. A sequence of palpations for the masticatory system is a matter of personal choice, and many acceptable ones have been suggested based on the location and various functions of the organs. All muscles and structures pertinent to functional masticatory disturbances are not accessible for palpation, but this should not deter us from accumulating as much information as possible from the many structures that are amenable to the technique. A logical sequence in palpating anatomical areas associated with functional disturbances of the masticatory system would be to first classify the areas to be examined on the broad basis of extraoral and intraoral sites. Our first palpations are directed to extraoral sites, beginning with the shoulders, neck, and epicranius regions. By beginning our sequence in these areas, the patient is introduced to and becomes familiar with the palpation technique and what is expected from her in the way of response. In turn, the examiner is aided in evaluating patient response before arriving at areas and anatomical structures with which the dentist is most concerned. Continuing the extraoral palpations, we proceed to the temporal and Masseter muscles and conclude by palpating the temporomandibular joints, which are first examined from the lateral surface and then from the posterior aspect. Next, intraoral palpations are performed on segments of the temporal and medial pterygoids, as well as the anatomical area lying close to the origin of the inferior belly of the lateral pterygoids. We should also search for and be cognizant of any abnormalities associated with glands, tissue spaces, and lymph nodes contiguous with and including the floor of the mouth and the tongue. Finally, a palpatory evaluation of the teeth should be done during occlusal contact relations in various mandibular movements. It is preferable when palpating joints and muscles to examine and compare pairs simultaneously and mutually in order to determine any differences and to evaluate responses from the patient. Most palpations are performed with the examiner either standing or sitting facing the patient. However, a few palpations are more easily performed with the examiner positioned behind the patient. The patient is instructed beforehand that the examiner is searching for tender or painful areas and that she should indicate to the dentist whether any discomfort or pain is felt from the palpation and whether it is more pronounced on one side or the other. A vocal response of uncomfortable is considered negative. Painful is regarded as a positive sign of tissue inflammation or injury. At the same time that the vocal response is being given, the examiner should observe carefully whether the patient presents any reflex signs, such as an eye blink or a flinch. If a response occurs, the palpation should be performed again to confirm the result. If no response occurs, proceed to the next site. When palpating, the dentist should compress the tissue gently but firmly and move his fingers in a back and forth or circular manner without leaving the base location. Not only should the examiner be on the alert for tenderness or pain, but concomitant factors in muscles such as timing of movement or contraction, hardness or softness, and hyper or hypotrophicity. One should also observe and mentally compare one side with the other and with normal and abnormal tissues previously found in the same or previous patients. As one progresses from site to site, the examiner becomes more familiar with the degree of response a patient elicits, and he is better able to judge whether or not the responses are exaggerated or normal. With experience, the examiner should become increasingly adept in clinical evaluation of the patient's responses and more discerning as to which responses are significant and which are not. Whenever possible and practical, palpation should be undertaken with the tissues or structures in the postural position, and then during various functional movements. Now, I would like to demonstrate these palpations on a patient. The examination of the neck and adjacent structures is well known to be one of the most important regions of clinical evaluation outside of the mouth. The area can be of significant value in a differential diagnosis of masticatory dysfunction from several standpoints. First of all, palpation of the lymph nodes in this region may reveal the presence of infectious disease in the masticatory area, or one may detect some of the first indications of tumors or metastasis of malignancies from other regions in the patient. Certainly, the examiner should constantly keep in mind the possibility of systemic involvement in the local areas in which he is concentrating. Secondly, palpation of the shoulder and neck region is important in detecting tender or painful muscle areas which may affect positioning of the head and mandible, thereby indirectly influencing the function of the masticatory system. Furthermore, investigations have shown that pain referred from myofascial areas in neck muscles may be mistaken for apparent primary masticatory pain and may mislead the examiner into an improper diagnosis of masticatory dysfunction alone when both cervical and masticatory disturbances are present. Under such circumstances, treatment planning could be significantly affected to the detriment of both the patient and the dentist. Prior to palpating the neck and shoulder areas, the patient should be positioned in the dental chair in an upright position without head support. Such a position will serve two purposes. First, it allows the neck muscles to assume a natural, relaxed state of tonicity, and secondly, it will enable the dentist to move the patient's head freely in order to bring certain muscles into various functional positions during palpation. Finally, it allows a more easy access to several sites of palpation. Before palpation of the neck is begun, the examiner should first inspect the neck for signs of contour differences between similar areas, as well as for any uncommon swellings or surface discrepancies. Neck palpations are begun on the trapezius muscles. For purposes of demonstration, we have asked the patient to remove her jacket and to pin up her hair. Palpations are begun with the examiner facing the patient and bilaterally placing the palmar surfaces of the fingertips on the origin of both trapezius muscles at the medial and inferior area of the superior nuchal line on the occipital bone. The fingers are then moved slowly downward and laterally to the distal third of the superior surface of the clavicle. The remainder of the muscles are palpated from shoulder to midline. Palpations of most significance to us are those done first with the muscles at rest, followed by the patient turning the head from side to induce contraction, and finally drawing the head directly backward while we maintain pressure with our fingers in the area of the origin of the trapezius in the occipital area. The next neck palpation is of the sternocleidomastoid muscles, which originate on each side of the sternum and clavicle by two heads, then pass obliquely upwards across each side of the neck and insert on the mastoid process just behind the ears. Investigators have shown that these muscles, when in spasm, may refer pain to the joint or ear region. This is a bimanual palpation, performed with the examiner facing the patient and starting at the mastoid area with the first two fingers of each hand and proceeding downward to the origin at the sternum and superior third of the clavicle. The palpations are first performed with the subject at rest, and then, while turning the head from one side to the other, to allow a comparative evaluation of the muscles in function. A more discerning inspection of these muscles can then be accomplished by bidigital palpation of the entire length of each muscle with the patient's head turned in the opposite direction from the muscle palpated. The last muscles to be palpated in the neck region are the digastrics, composed of anterior and posterior segments. Their action in aiding depression of the mandible is well known. Although palpation of the posterior segment of the digastric muscles may be possible, information regarding the status of this portion in some patients may be questionable. The various anatomic structures surrounding these muscles, such as the parotid gland, lying superiorly and laterally, with various lymph nodes and vessels coursing through its body, the sternocleidomastoid muscle, lying posteriorly and laterally, and the stylohyoidus muscle, inferiorly and laterally, as indicated by the crosses, may adversely influence one's interpretation regarding muscular tenderness or consistency. Furthermore, the area to be palpated is so limited in area that the finger size of the examiner might well hinder a meaningful palpation in some patients of small stature. However, in patients wherein palpation of the distal segment of the digastric appears achievable, the patient is first asked to tilt the head backward against the headrest. Since this palpation is performed bilaterally, the forefingers, or little fingers if necessary, with the palmar surface placed medially, should be placed parallel and anterior to the long axis of the sternocleidomastoid muscles, and pressure should be applied inward and upwards into the sulcus located between the posterior border of the ramus of the mandible and the anterior border of the sternocleidomastoid. One should exercise caution not to inadvertently press on a symptomatic sternocleidomastoid during this palpation. Once the digastric has been palpated at rest, the patient is then asked to open widely and then to close and retract the mandible. Any indication of tenderness is noted comparing one side with the other. Next, we move to the anterior segment of the digastric muscle, which is more amenable to palpation because of its location close to the surface of the chin. With the patient's head moved forward and supported by the headrest, the forefingers on each side are brought downwards and forward from the posterior segment of the digastric and pressed intermittently upward against the lower surface of the chin while the mandible is in the closed position. Once the anterior limit of the muscle is reached at the anterior border of the mandible, the patient is asked to open the mouth. Then close the mandible while the muscle is again palpated during function. The next region to be palpated is the head, beginning with the epicranius, a broad muscular and tendinous layer extending over the vertex and parietal portions of the skull from the occipital bone to the eyebrow. Knowledge of tenderness and pain in this muscle layer may be of significance in evaluating its involvement in pain and headache symptoms in the area. The occipital segment of the epicranius, as well as the galea epineurotica portion, is bilaterally palpated by pressing with all fingers of both hands on the occipital region of the head from the superior nuchal line upwards and including the vertex, being careful not to press on the superior fibers of the temporalis muscle. The palpation of the frontalis muscle is now performed as the fingers are moved from the vertex slowly forward and downward until the eyebrows are reached. An alternate method for palpating the frontalis is with the thumbs, while the fingers of both hands are retained on the parietal area just palpated. We now proceed to extraoral palpation of the masticatory muscles. The first area to be examined is the origin of the temporal muscle. Once again, we are able to perform bilateral palpations, thereby allowing a comparative evaluation of the structures examined. The temporal muscle has 3 segments, all of which originate in the temporal fossa on the lateral surface of the skull. The fibers converge as they descend and end in a tendinous insertion on the medial surface, apex, and anterior border of the coronoid process, and the anterior border of the ramus of the mandible, nearly as far forward as the 3rd molar tooth. Because of the complexly integrated functions of the various muscles of mastication, it does not seem advisable to attribute a single or principal action to any single muscle. The temporal muscles in particular, composed of 3 functional components, are responsible for several different movements of the mandible. Their principal action is to position the mandible during elevation and serve as retractors of the mandible. All of these diverse actions should be performed during palpation of each muscle segment while the examiner faces the patient in order to notice any reflex responses to pain or tenderness. Beginning with the posterior aspect of the muscles, press the palmar surfaces of the 2 fingers of each hand against the areas above and distal to the superior border of the ears. The fingers are moved back and forth and in a circular motion while the mandible is in the rest position. Then, when lightly closed, and then while the patient clenches, and finally during mandibular retraction, which is one of the principal actions of the posterior portion of the temporalis. Palpations of the middle and anterior portions of the temporals are similar to those for the posterior portion. It should be re-emphasized at this point that although we are constantly searching for tenderness and pain, we also should direct our attention to the volume and tonicity when palpating muscles. Our palpation extends down until we reach the zygoma, at which point the muscle courses medially and cannot be palpated. The masseter is the next muscle to be examined. It is a very powerful muscle composed of 2 main bundles of fibers, one superficial and one deep. The deep portion is palpated bilaterally by placing the forefingers approximately 10 millimeters anterior to the TMJ and just inferior to the posterior third of the zygoma. Pressure is applied with the mandible at rest, and then the patient is asked to clench. Next, the superficial or lateral portion of the masseter at rest is palpated, beginning by bilaterally placing the 2 first fingers, or else the thumbs, just along the inferior border of the zygomatic processes and following the anterior border downward until the gonial angle is reached, and that area is then palpated using 2 or 3 fingers for a more efficient coverage of the area. We now ask the patient to alternately clench, then open and close the mandible as we perform the same palpations in a reverse direction. Just keep right on opening. A more discerning inspection of the belly of the muscle may be made by placing the thumbs intraorally on the anterior border and the forefingers on the lateral aspect of the masseter. We now conclude our extraoral palpations by examining the temporomandibular joints. Prior to temporomandibular joint palpations, the clinician is urged to observe the tissue surface of both joint areas for signs of swelling and redness, which might indicate inflammation associated with such disease entities as hyperuricemia, infectious or rheumatoid arthritis, or traumatic injuries. Under the latter 4 circumstances, palpation is often impractical, and if carried out, should be done with extreme gentleness and caution. Even then, patient response can be very confusing and of less value diagnostically than if purely functional disturbances are present. Two areas are commonly palpated relevant to examination of the temporomandibular joints. First, the lateral surface of the joint, located approximately 13 to 15 millimeters anterior to the external auditory meatus. And secondly, the posterior aspect of the joint, which is reached by digital palpation via the external auditory meatus. Both palpations are done with teeth lightly occluded, then clenched, in order to compare and determine slides and pressures between the joint surfaces. While doing the lateral palpation, the examiner should place the index fingers on the condylar surface, and then the patient is asked to slowly move the mandible into wide opening. Now close. Now into protrusive. Back. Now into retrusive. Now finally into lateral excursions. The eccentric movements are all first performed with the teeth apart to exclude any proprioceptive influence from the periodontal ligaments, and then with the teeth occluded. The temporomandibular joints are compared for differences in size, smoothness, and timing of movements when the teeth are occluded and when apart. Notes should be recorded on all significant aspects such as tenderness, pain, timing of tripping or jumping, sounds such as clicking or crepitus, limitation, and whether or not the individual condyles move symmetrically with respect to one another. Most examiners perform another joint palpation, which is accomplished by inserting the little finger in the external auditory meatus and pressing the palmar surface against the cartilaginous anterior wall, thereby indirectly exerting pressure on the lateral third of the posterior aspect of the joint, which is composed principally of the condylar head, capsular ligament, and retroposterior attachments. Before performing this palpation, the patient should be asked if any pain or discomfort has been noticed recently in this area, and as a precautionary measure, the pinner of the ears may be pulled downwards to reveal any tender or painful areas within the outer portion of the canal, which would preclude palpation at the time of examination. If the area is amenable to palpation, the examiner should first palpate the site bilaterally while the patient's teeth are in light centric contact and then in the clenched position. The patient is next instructed to move the mandible in all the various excursions from centric. Comparisons and correlations are noted, as was done with the lateral surface palpations. Following the joint palpations, the examiner should determine any periarticular swelling or areas of localized tenderness or pain. Caution should be observed during all of the lateral surface palpations of the joint not to encroach on the deep body of the Masseter, which lies approximately 10 millimeters anterior to the joint. This is a bilateral palpation, which is accomplished by having the patient open wide while the examiner presses the index finger against first the lateral or superficial tendinous attachments and then the medial or deep tendinous attachments, which lie on either side of the retromolar fossae. The palpations are begun just behind the second or third molar areas and are terminated when the superior limit of the palpation of each tendon is reached. It is usually advisable to palpate back down to the starting point of palpation of each tendon. The deep or medial tendon is usually longer and stronger and more easily discernible than the superficial tendon. The majority of fibers composing the origin of the medial pterygoid muscles are inaccessible to palpation because of their location deep in the pterygoid fossae and on the medial surface of the pterygoid plate. However, the insertion of this muscle on the medial surface of the mandibular angle may be palpated both intra and extraorally. Palpation of the medial pterygoid is performed unilaterally and bimanually. Although this method does not allow a simultaneous bilateral comparison of the two muscles, it is desirable in most patients. It is particularly desirable in those patients who display limitation of movement and whose mouths are too small to allow an intraoral bilateral palpation. It is executed by having the patient move the head downward to relax the suprahyoid muscles and neck musculature, as well as any skin tension adjacent to the mandibular angle. The examiner is thereby able to place the index and second fingers of one hand up under the lowermost fibers of the medial pterygoid at their insertion on the medial surface of the mandible. Simultaneously, the forefinger of the other hand is moved in under the tongue and slid posteriorly, inferiorly, and medially until the tip, in many instances, reaches the fingertips palpating from the gonial angle area. The operator then should move the intraorally placed fingertip upward along the belly of the medial pterygoid until the muscle is no longer amenable to palpation due to intervening structures of the palatal and pharyngeal region. Whether or not the lateral pterygoid muscle can be palpated directly is a matter of speculation and controversy. Certainly the anatomical position of the insertion of the superior portion is inaccessible to palpation, as is the insertion and belly of the larger inferior portion of the lateral pterygoid muscle. However, it appears that the lowermost fibers of the origin of the inferior portion, together with a tiny slip of the origin of the medial pterygoid, respond dramatically to pressure exerted in the retrozygomatic zone. Whether or not the lateral pterygoid itself is directly contacted beneath the oral mucosa, or whether the pressure of tissue fluids and other underlying anatomical components are indirectly forced against the muscle, is presently a matter of conjecture. It has been our experience that when pain, discomfort, and other symptoms commonly associated with functional disturbances of the mascatory system in this region are relieved with successful treatment, the tenderness to palpation in this area will no longer occur. Since this palpation can cause excruciating pain in some patients, extreme caution is advised for this procedure. The patient should be forewarned that some discomfort may be felt. Also, the dentist is urged to utilize a finger caught when performing this palpation so as to prevent scratching of the mucosa from the examiner's fingernail, which may set off a deceptive positive response. The patient is asked to open and to move the mandible to the side to be palpated. This movement will move the coronoid process laterally and thereby provide more space for the examiner to insert a finger into the area to be palpated. Since the space, referred to by some as a retrozygomatic space and by others as the most posterior segment of the buccal vestibule, is quite restricted in size, the little finger is perhaps the best choice to palpate this area in most mouths. The finger is moved posteriorly along the buccal vestibule and then position so that the palmar surface of the fingertip can press against the posterior surface of the tuberosity. The fingertip is then slowly moved superiorly and medially as far up into the sulcus behind the tuberosity as is possible. Gentleness is of the utmost importance during this final movement so as not to produce a false response. Each side is palpated and a comparison of the tenderness is made both by matching reflex actions and asking the patient for their evaluation. Palpation of the teeth is undertaken to detect tooth mobility during various occlusal contacts both in centric and during excursive movements. On occasion, some inconspicuous prematurities and interferences may be detected better by palpation than by occlusal marking devices or visual observation. Furthermore, during gliding movement in lateral and protrusive excursions, surface roughness or unevenness due to ledges or defects in the tooth surface may be brought to the attention of the examiner. Fremitus is involved in these palpations. The technique for these palpations involves placing the ball of the index finger over the tooth so that both the crown surface and the mucosa overlying the root are contacted simultaneously. The patient is asked to close the teeth together in light centric contact and then to clench in centric occlusion. The contacts are then repeated when possible in centric relation with the examiner placing the mandible in the retruded position. Just come up gently. Now squeeze. Good. Once more now. Come up until you gently touch, hold it. Now squeeze. Good. Finally, the patient is asked to move the mandible into all excursions while maintaining pressure on their teeth. These movements are performed with the examiner maintaining the patient in the retruded border position. Okay, Carol, now just close. Now slide over to this side. Good. Again. Back to normal. Once more. Right over to this side. Back to normal. Now to the other side. Slide right over to the side. To the other side. Back to normal. Now straight forward. Back to normal. Once more. Back to normal. Some patients with very tender teeth, muscles, or joints may not be able to fully cooperate in these exercises. However, a significant number will be able to cooperate, making these palpations a worthwhile adjunct in performing a thorough examination for patients with dentally related functional disturbances. The clinical examination of patients with functional disturbances of the masticatory system should incorporate as many acceptable diagnostic tools and methods as possible to ensure a thorough and complete inspection, leading to a proper diagnosis prior to initiating treatment. Palpation of teeth, muscles, and temporomandibular joints has been found by many to be one of the most useful and beneficial methods of clinical examination. The results of palpation alone, whether positive or negative, should not be thought of as being conclusive in determining a definitive diagnosis. However, in many instances, palpation can be of significant value when correlated with other clinical methods and findings in reaching a practical diagnosis. This tape has been produced to explain the principles and techniques of palpation and to illustrate a sequence of steps and techniques which can be used in palpating teeth, muscles, and joints relevant to a clinical examination for functional disturbances of the masticatory system.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.